What is hypertension? Sustained increase in blood pressure. The real problem of hypertension is the risk of developing hypertension-related cardiovascular diseases. Increase in blood pressure could lead to changes in blood vessels and remodeling of the heart, leading to cardiovascular diseases. Blood pressure equals pressure in arteries when the heart is contracting. It is called systolic. The systolic blood pressure equals the cardiac output times the resistance in vessels. When the heart is relaxing, it is called diastolic blood pressure. In the pre-hypertension stage, there is a high risk of developing hypertension. No medication required at this stage. Lifestyle changes is required. Weight loss, dietary approaches to stop hypertension, sodium restriction, physical activity, and smoking cessation. A clinical hypertension is based upon 2 or more seated blood pressure measurements on 2 or more occasions. In most patients, the target blood pressure value is lower than 140/90 millimeters of mercury. In diabetic patients and chronic kidney disease patients, blood pressure goal is lower than 130/80 millimeters of mercury. Evaluated 1 to 4 weeks after therapy initiation or modification. Initial blood pressure lowering needs 1 to 2 weeks, but steady blood pressure up to 4 weeks. Average of 2 measurements is used. Standing blood pressure measurement for orthostatic hypotension evaluation whenever dizziness occurs. Classification of hypertension. Primary hypertension essential. 90 to 95% of cases are termed primary hypertension, which refers to high blood pressure for which no medical cause can be found. Genetic factors, environmental factors, obesity, alcohol intake, stress, and smoking. Secondary hypertension. 5 to 10% of cases are caused by other conditions that affect the kidneys, arteries, heart, or endocrine system. For our body to regulate the blood pressure, it needs to control the cardiac output and the peripheral resistance. There are 3 ways to regulate the blood pressure: through the endothelial factors, the baroreceptors, or the renin-angiotensin-aldosterone system. How does the vascular smooth muscle contract? Calcium levels should increase through voltage-gated calcium channels, L-type calcium channels after depolarization, and through GPCR, G-protein coupled receptors, especially GQ receptors, which activate PLC, phospholipase C, and increase the levels of IP3, inositol triphosphates, that increase calcium. Calcium then binds to calmodulin, forming calcium-calmodulin complex, which activated the myosin light chain kinase, MLCK. It phosphorylated myosin to myosin phosphate. The myosin will slide over the actin and contraction occurs. Controlling calcium levels regulates the blood vessels movements, the vascular smooth muscle tone, the peripheral resistance, and the blood pressure. Endothelial factors. Nitric oxide increases cyclic GMP, which decreases calcium levels. They activate myosin light chain phosphatase that removes the phosphate from the myosin, causing relaxation. Prostacyclin acts on IP receptor, which elevates the level of cyclic AMP, decreasing the calcium levels, causing relaxation. Endothelial-derived hyperpolarizing factors. They cause hyperpolarization. They decrease the calcium entry, leading to vasodilation. These 3 factors are released from the endothelium, leading to relaxation of the vascular smooth muscle. The next 3 factors, they increase the calcium levels. Angiotensin II acts on AT1 receptors, GQ, increasing calcium levels, causing vasoconstriction. Prostaglandins, they act on TP receptors, GQ, increasing calcium levels, causing vasoconstriction. Endothelin acts on ET receptors, increasing calcium. Baroreceptors, sometimes called stretch receptors or mechanoreceptors, found in the wall of aortic arch and carotid sinus. During any severe alteration in arterial blood pressure, they try to return it to normal. They send impulses to 3 centers in the CNS. VMC, vasomotor center, increases sympathetic tone to blood vessels. CAC, cardiac accelerator center, increases sympathetic tone to the heart. CIC, cardiac inhibitory center, increases parasympathetic tone to the heart. When blood pressure decreases, for instance when you sit for a long time and you suddenly stand up, the baroreceptors try quickly to activate the CAC and VMC to increase the blood pressure to prevent orthostatic hypotension. Renin-angiotensin-aldosterone system. Decrease in arterial blood pressure decreases renal blood flow. Renin release converts angiotensinogen released from the liver to angiotensin 1. The angiotensin converting enzyme released from the lungs and kidney converts angiotensin 1 to angiotensin 2. Angiotensin 2 acts on AT1 receptors. It causes direct vasoconstriction. It increases the level of aldosterone, increasing sodium and water retention, and increases the sympathetic tone centrally and peripherally. All this increases blood volume, cardiac output, and pressure, increasing arterial blood pressure.